Hello guys and welcome to the interactions or drug interactions, and I just want to welcome you also for the detailed discussion of drug interactions, which may take a while since we are going to tackle the interactions one by one and the effects that will arise with the said interaction of drugs. It is important for you to familiarize yourself with the common drug interactions because this is going to be one of the biggest part of your role, and it will separate you from the other medical professionals when dealing with the medications, not only to their side effects, but also from their other downsides or other effects. So let's begin. Drug interactions, also known as therapeutic incompatibilities, this is the adverse drug response produced from the administration of a drug with another, resulting to the modification of patient response to it. What are we trying to configure with this one is that when you have taken a drug concomitantly with another one, there will be an interaction which it may alter your response to it, or it may cause a good clinical effect depending on how the interaction occurs. With regards to this, drug interactions can be intentional or unintentional. Intentional drug interaction is an interaction in which you are voluntarily taking two medications because you want something from them when combined. Meaning, sinasadya mo talaga silang inumin together kasi alam mo na kapag ininom mo sila ng sabay, mas maganda ang effect. One good and common example to this one is glutathione and vitamin C, or Myra E plus vitamin C. The patients wanted to combine these type of medications together because they know that the effect will be intensified, in a sense that vitamin C will enhance the effect of glutathione or vitamin E by means of protecting your cells and your immune system to foreign toxic compounds. Parang sasabihin ni vitamin C kay glutathione or kay Myra E, sige, ako na bahala dito sa mga free radicals na to. Do what you needed to do. In which the point is, kung wala si vitamin C, si glutathione, imbis na magawa niya yung dapat niyang gawin, magsisegue pa siya sa iba. Another example is Combizar. Ano ba ang generic name ni Combizar? Losartan plus hydrochlorothiazide. Di ba alam naman natin na si losartan ay antihypertensive at diuretic naman si hydrochlorothiazide. Ano ba naman ang reason bakit natin kino-combine yung dalawa? The answer is, there are a lot of factors why our blood pressure is shooting up. Isa na rito yung kapag constricted ang blood vessels natin dahil sa angiotensin. Hindi makadaloy ng maayos yung mga dugo natin, ang magiging response ng heart, lalakasan niya ngayon yung pag-pump niya para makompensate yung normal circulation natin. Ngayon, ang ginagawa ni losartan, yung constricted blood vessels natin, idadilate niya via angiotensin 2 receptors. So, i-antagonize niya yung angiotensin 2 receptors, kumbaga. Ano naman ang role ni hydrochlorothiazide? Minsan kasi tumataas ang BP natin dahil dun sa mataas na volume ng fluid natin sa katawan. Ang ginagawa ni hydrochlorothiazide, mag-act siya sa kidneys natin para hindi i-reabsorb ni kidney si sodium. Diba, where sodium goes, water goes. So kapag hindi na reabsorb si sodium, i-excrete natin siya dahil nga again, where sodium goes, water goes, sasama si water sa sodium na ma-excrete. Bababa ang volume ng fluid natin sa katawan, so bababa din or mag-normalize ang blood pressure natin. Kaya nga, di ba, ang unang pinapagawa sa atin kapag may hypertension tayo is bawasan ng maaalat na pagkain. Yun ay dahil para hindi tayo magkaroon ng fluid retention. Next is unintentional drug interaction. This is an interaction that occurred because you want something, you don't want something on purpose or inadvertently, or hindi ka aware na hindi ka pala na-educate ng prescriber or ng pharmacist, or baka winiin lang kung mas maganda yung effect niya ba over the side effect or other so. One good example naman dito is uminom ka kunwari ng ciprofloxacin kasi may UTI ka, niresetahan ka ni Doc ng ciprofloxacin. Tapos dahil hindi ka aware, uminom ka ng gatas kasi may nakita kang fresh milk sa ref. Well, it's a no-no. Bakit? Ang ciprofloxacin kasi nag-i-interact siya sa mga divalent or trivalent compounds like calcium in the form of milk, aluminum, magnesium, ferrous, or etc. Basta yung chemical formula Mi2 plus o 3 plus like Ca2 plus, Al2 plus, Mg2 plus. Ang mangyayari, yung ciprofloxacin, magpo-form siya ng complex na hindi absorbable. So meaning, ma-excrete siya. Therefore, bababa yung effectivity ng ciprofloxacin para sa UTI mo, and then magkakaroon ka ng high risk for failure ng therapy. At alam naman natin na kapag ang antibiotic nag-fail, magkakaroon na ng resistance si bacteria. So gagamit ka ng mas malakas na antibiotic which is more toxic in your liver and kidneys and mas mahal. Now, let us move on with precipitant versus object drug. Precipitant drug, these are the drugs or chemical that causes the interaction. Meaning siya ang may kagagawan ng interaction. Ang object drug naman, drug affected by the interaction. Meaning siya yung naaapektuhan sa kagagawan ni precipitant drug. Sample natin si ciprofloxacin ulit and si ferrous sulfate, which is na-discuss ko na to kanina, pero let's move into details. Ciprofloxacin plus ferrous sulfate. As previously discussed, di ba magpo-form ng complex or mag-cicellate si ciprofloxacin sa mga divalent or trivalent cations. Ang ferrous ay isa sa mga divalent. So pag pinagsabay mo itong dalawa, magkakaroon ka ng interaction, just like what I've said earlier. Ang tanong, alin dito sa dalawa ang precipitant at alin naman dito sa dalawa ang object drug? For example, may UTI ka, nagtitake ka ng ciprofloxacin. Tapos si doc napansin niya, anemic ka. So niresetahan ka niya ng ferrous sulfate. Sino ngayon si precipitant drug? Siyempre si ferrous. Kasi iniinom mo na si ciprofloxacin bago mo pa inumin si ferrous. So kung isasabay mo si ferrous kay cipro, bababa ang effect ni cipro, and the best way for them not to interact with each other is magpalipas ka ng 6 hours bago mo inumin si ferrous sulfate for them not to form a complex that is not absorbable. So, ulitin ko, ang ating precipitant drug ay si ferrous sulfate kasi siya ang mag-cause ng interaction kung bakit bababa ang effect ng ciprofloxacin. Ngayon, paano naman kung nagkabaliktad ang sitwasyon? For example, umiinom ka na talaga ng ferrous sulfate kasi na-anemic ka, tapos binigyan ka ni doc ng ciprofloxacin kasi based sa yung analysis mo at sa assessment niya, may UTI ka. Ang gagawin mo lang is magpalipas ka ng 2 hours bago mo inumin si ciprofloxacin to avoid such interactions. Okay? So next, there are 2 types of drug interaction. Una is yung pharmacodynamic interaction. This is an interaction in which the resulting effect of one drug is altered by the presence of another drug on the site of action. As we all know, pharmacodynamics is what the drug does to the body. So these interactions occur, So these interactions occur because drugs with additive or opposing effects lang. Hindi tayo magbe-base sa concentration. So uulitin ko, additive or opposing effects lang. Meaning wala tayong pakialam sa concentration ng gamot sa mga ganitong type of interaction. Kasi uulitin ko ulit, additive or opposing effect lamang tayo sa pharmacodynamic interactions. Now, on the other hand, pharmacokinetic interactions occur when drug changes the systemic concentration of another drug, altering how much and for how long it is present at the site of action. So meaning, ang focus natin dito is yung concentration. Kasi nga, di ba, from the meaning, what the body does to the drug, ano ba ang gagawin ng body natin sa gamot? It may increase or decrease the activity or toxicity of the drug, and it will affect the ladmer. Ano ba yung ladmer? Liberation, administration, distribution, metabolism, excretion, and response, which is technically discussed na noong biopharmaceutics and pharmacokinetics subject natin. Factors affecting drug interaction. Alam ko na-discuss na sa inyo to ni Sir JP, so i-rundown na lang natin sila. Okay, first, polypharmacy. Ito yung marami kang iniinom na gamot, lahat na ng anti-ininom mo na. Siyempre, isipin mo na lang chemical yan. Magkakaroon ka talaga ng interaction pag masyado ka ng marami iniinom na gamot. Kaya ang role nyo, wait, role natin pala as a pharmacist, o nga pala, pharmacist na pala ako, is to identify ano ba ang pwedeng i-omit sa mga medications na yun to reduce interactions and also the adverse events. Kasi nga, pag masyado ka maraming iniinom na gamot, mataas ang risk mo for drug interaction. So, hindi rin maganda na lagi kang umiinom na maraming gamot kasi feeling mo gagalitan. No, it's a no-no. Kailangan mo pa rin i-consider ang drug interaction. Next, multiple pharmacological effects. May mga gamot kasi na non-selective tulad ni propranolol. Alam naman natin na ang propranolol ay beta blocker, pero non-selective siya. Meaning, pwede siya mag-act sa heart and sa lungs. So kung may iniinom ka pang pangbaga mo at uminom ka din ng propranolol, may effect yon for sure. Next, multiple prescribers. Pag nagpapa-second opinion tayo, feeling mo kasi hindi magaling si Doc A. So kukonsulta ka ngayon kay Doc B. Hindi sila pareho na may reseta sa'yo. So ikaw naman, sa kagustuhan mong gumaling, ininom mo yung nireseta ng dalawa. So ano mangyayari na yun? Possible ka magkaroon ng drug interaction. Kasi nga, ang dami mo na namang gamot na iniinom, so magra-rundown ulit tayo, babalik ulit tayo sa polypharmacy. Next naman is yung patient non-compliance. Ito naman yung mga kapag hindi ka sumusunod sa dosing regimen mo. Kunwari, si patient A may maintenance na antihypertensive, pag feeling niya, magaling na siya, hindi na siya iinom ng gamot niya. And this is normal for those patients taking maintenance because sometimes they are tired of thinking and drinking and also thinking how much they are taking every day. Kasi nga, diba, mahal ang gamot. So, next. Patient risk factors like disease state, age, use, non-prescription drugs, and food supplements. So, punta tayo sa age. Anong kinalaman ng age? Number one, as we all know, pediatric patients' metabolism is not full-blown. Hindi pa siya full-blown. So, kumbaga, hindi pa na-develop yung buong katawan ng bata. Andun pa siya sa stage na nag-develop siya. So, ang ating enzymes ng mga bata tayo ay hindi pa kompleto. So, kailangan natin i-consider ang dose adjustment when giving doses to the pediatric patients. Like for example, ikaw may sakit ka, hindi mo naman bibigyan ng 500 milligrams ang pasyente mo na bata pa. Normally, ang binibigay sa kanila, di ba, yung mga nakasirop, tapos ang mga dose lang nila is 125 milligrams per 5 ml or 250 milligrams per 5 ml in the brand name of Tempra or Digest, parang ganon. Kasi nga, hindi pa kompleto yung enzymes nila, so kapag binigyan mo sila ng mas mataas na dose, there are chances na magkakaroon sila ng toxicity. Next, geriatric patients. Ang common na check sa mga geriatrics is the liver function test, most specifically aspartate aminotransferase or AST and alanine aminotransferase or ALT. Ano naman tong dalawang to? Ito yung two parameters na chine-check sa ating liver function na kapag times 3 higher than the normal limit na siya, kailangan na natin i-consider yung dose adjustment. Kasi nga, baka meron ng underlying cause bakit nagkakaroon na ng pagtaas ng AST and ALT kasi in the normal person or a normal healthy person, hindi mataas ang AST and ALT natin. Pero you don't have to worry if mataas ang ALT nyo just above the normal limit. Like for example, ang normal limit natin is 125 to 150. Just for example, hindi ko alam yung totoong reference range niya. For example, 150 ang upper limit, tapos ang ALT mo ay 157. Yes, mataas siya, but not that clinically significant kasi nga kailangan 3 times higher than the normal limit kasi pwede palang false positive lang, kaya lang tumaas yung ALT mo. So, next, yung kidney naman natin, ang mini-measure natin dyan yung creatinine clearance. Kasi ang kidney, ang taga-filter natin, di ba? So, meaning, pag ang creatinine clearance mo is 75 to 125 ml per minute, may problem ka siguro sa kidney, so pwede mo na itong ipacheck kay doc. And dose adjustments should be considered to this kind of patients. Next, disease. As I have said earlier, liver and kidneys are the most common in drug interactions kasi nga ang liver ang nag-metabolize, ang kidney ang nag-excrete or nag-assist sa excretion ng gamot. So silang dalawa ang pinaka-common at ang pag nagkaroon ng disease, ang dalawang ito, possible na magkaroon din tayo ng toxicity sa ating mga iniinom na gamot. Next is substance abuse. Tobacco cigarette may cause enzyme induction. Sa madaling salita, ang paninigarilyo ay nag-cause ng pag-release ng enzyme natin. Alam naman natin na kapag mataas ang enzyme natin, mabilis ang metabolism natin. Kaya tignan nyo yung ibang malakas na nigarilyo, ang bilis nila mag-metabolize. Some of them, maano pa, payat. Yung iba payat pa. Kasi nga, mabilis ang metabolism nila. So, ang pag-burn nila ng fats nila ay mas mabilis din. I'm not saying na kung mataba ka, magsigarilyo ka para lang pumayat ka because that is not a good thing to do. Okay? Next, alcoholism. Acute alcoholism may cause enzyme inhibition, meaning na i-inhibit ang release ng enzyme for metabolism. So kapag acute alcoholic ka, ano ba ang ibig sabihin ng acute alcoholic? Hindi ka ganun kalala uminom ng alcohol. Occasional but more than occasional taong inom. Kasi yung chronic, di ba? Kapag chronic alcoholism ka, parang everyday na lang umiinom ka na ng gamot, parang you can't live without alcohol in your system. So ngayon, kapag acute alcoholic ka at uminom ka ng gamot, there are chances na hindi na may metabolize in a normal rate yung drug na iniinom mo. So mas magsistay siya sa katawan mo. Tapos alam naman natin na kapag hindi nag-excrete ang gamot natin na ininom natin, magiging toxic siya sa katawan natin, lalong-lalo na kapag ang mga metabolites, kailangan na natin talaga sila i-excrete. In chronic alcoholism, enzymes are induced. Same as in tobacco and cigarette use, it will increase the rate of metabolism of a certain person. Just like what I said earlier. Now, let's move on with the genetic factors. Fast acetylators and slow acetylators. Fast acetylators are enzyme-induced people. So sila yung mabilis mag-metabolize. Mabilis ang metabolism nila. And tayo yon mga Asians. Asians ang mga mabibilis mag-metabolize. Sa kabaliktaran naman, ang mga Caucasians or the slow acetylators naman, mabagal sila mag-metabolize. So nagbavary ang dosing based on the genetic factors. Example dito ay, ano bang good example? Like for example, biogesic na lang. Sa Pilipinas, ang biogesic natin, ang common dose na is 500 milligrams. But in the United States, yes, meron na tayong 675 milligrams of paracetamol doon. Pero meron din silang available doon na 325 milligrams because they are also considering the genetic factors that they are a slow metabolizer. So kapag baka mamaya kinompute yung mga parameters, tapos nagbigay sila ng 500 milligrams, it may cause toxicity na for them. But, syempre, paracetamol yan. Alam naman natin ang paracetamol, iti-take nyo na madami bago pa magkaroon ng toxicity. But, what if sa ibang gamot, di ba? So, ang gusto ko lang i-point out dito, dosing is also affected by the genetic factors and drug interactions is actually being affected by dosing, which is in turn, magkakaroon pa rin tayo ng bad effect if hindi natin consider yung dalawang to. Now, let's move on to the drug-drug interactions. This is the interaction of two drugs when taken together concomitantly. So, drug and another drug. Kasi meron tayong mga interaction of drug and food, and drug and laboratory, or drug and device. Marami tayong types of interaction, pero mag-focus muna tayo sa drug-drug interaction. Duplication. Intensification of effect when two drugs with same active ingredient or with the same action are taken at the same time. Ano bang ibig sabihin nito? This is the intensification of effects when two drugs when taken together because they have the same ingredients or they have the same action. Therapeutic duplication warnings are only returned when drugs within the Therapeutic duplication warnings are only returned when drugs with the same group exceeded therapeutic duplication maximum. Ano bang ibig sabihin nun? Meaning, hindi porke nagkaroon ka ng duplication ay masama na agad or harmful na agad siya. For example, uminom ka ng multivitamins. Kaso, may sipon ka, gusto mo mag-take ng extra vitamin C. Okay lang naman yun, knowing na may duplication nga, pero since multivitamins has a small amount of vitamin C, then if gusto mo naman dagdagan yung vitamin C mo, take another 500 milligrams, it doesn't matter. Kasi kung ang vitamin C naman, pag nasobrahan, iihi mo naman siya kasi isa siya sa mga soluble drugs. Diba? Ang ating mga non-soluble drugs is ADEC, PDEK. Wala lang, yabang ko lang. Okay. So, punta tayo ngayon dito sa example natin dito. Example number 1. Kyle asked his neighbor Rodolfo if he can take Neosep due to his cold starting to worsen and take Bioflu because he feels feverish. Rodolfo then mentioned that he should take Bioges instead of Bioflu. Is there a therapeutic duplication? Yes. Bakit? Neosep at Bioflu, same sila ng generic name at magkaiba lang sila ng brand name. Ang generic name nila is phenylephrine plus chlorpheniramine maleate and paracetamol. May ibang patients kasi na kapag sinabing Bioflu, akala nila pang trangkaso lang yon. Pero ang Neosep kasi at Bioflu, same. Tapos sasabihin nila, ang Bioflu pang trangkaso, ang Neosep pang sipon, hindi nila alam na pareho lang sila. So ikaw as a pharmacist, dapat you educate your patient at the same time na binili nila ito sa'yo. Kailangan alam nila na same lang tong dalawang to. Hindi naman dahil harmful sila when taken together, but syempre, sayang naman yung pinambili nila na, kumari, bibili siya ng Neosep isang banig, bibili siya ng Bioflu isang banig. Yes, benta mo yon, pero i-consider mo din na lalo na ngayong pandemic, ang hirap ng buhay. So, kung kailangan naman natin silang tulungan para makatipid sila, then it's better mas fulfilling yun as a pharmacist. Also, Neosep plus Biogesic both contains paracetamol. Kasi nga, di ba, ang generic name ng Neosep is phenylephrine, chlorpheniramine maleate, and paracetamol. Biogesic has paracetamol. So, magkakaroon siya ng therapeutic duplication, pero same concept lang naman dun sa multivitamins plus vitamin C natin. Dinagdagan mo lang yung levels or in-intensify mo lang ang levels ng Biogesic kasi nga feverish ka. Pero hindi naman siya ganun ka-harmful kasi nga it takes a lot of paracetamol for you to become toxic or for the poisoning to occur. And meron din naman tayong antidote doon, but I am not telling you to try it at home, syempre. Now, example number 2, Kyle expressed experience sporadic diarrhea. Ano ba yung sporadic diarrhea? Irregular, sporadic irregular diarrhea, and took diatabs. He complained that he needed to be admitted to the hospital wherein he was given diphenhexylate plus atropine. After 4 hours, he suddenly felt constipated and was given Dulcolax as treatment. As assessed by the physician, Kyle's diarrhea was not bacterial in origin. So, hindi siya bibigyan ng antibiotic because it was not bacterial in origin technically. So, is there a therapeutic duplication? Yes. Diatabs and diphenhexylate both treats diarrhea, but if given at the same time, it may cause constipation. So, meron din tayong antagonism dito, diatabs and dulcolax. Anti-constipation yung isa naman anti-diarrheal, antagonism yun, which is, i-discuss natin yan in the next slide. Antagonism. Reduction of effectiveness when two drugs with opposing actions are taken together. Sometimes they are considered to be antidote of one another, or it is an antidote of a certain poisoning or effects. Example, Jessica was taking propranolol, which as I discussed kanina na ba ang propranolol ay non-selective. Okay, going back. Jessica was taking propranolol for hypertension as maintenance. Upon going to work, she experienced asthma and was given albuterol in the company clinic. Is there a therapeutic antagonism? Yes. Okay. Albuterol plus propranolol. In my previous example, we discussed that propranolol is beta blocker and it is non-selective. So if you are taking albuterol, okay, albuterol is the old name of salbutamol, so it may come hand in hand. If you are taking albuterol, may antagonism effect siya in a way na kapag may asthma ka, nakaka-experience ka kasi ng bronchoconstriction, di ba? Ang ginagawa ng albuterol, dinadilate niya yung bronchial airways natin para makahinga tayo or para ma-relieve yung symptoms ng asthma. Eh kung kasabay niya si propranolol na alam naman natin na bronchoconstrictor siya, marireduce ang effect ng albuterol or ng salbutamol, so meaning hindi magagamot yung asthma. Now, propranolol antagonizes the effect of albuterol, but it may also be given to patients who suffers from albuterol or salbutamol poisoning. So meaning it can also be an antidote for albuterol poisoning. So kung ikaw gusto mong magpakamatay dahil broken-hearted ka at nilanghap mo lahat ng albuterol o ininom mo lahat ng albuterol, ang ibibigay lang sa'yo for it to become, for you to become normal again or to counteract the effects of albuterol poisoning is propranolol. But again, I am not telling you na magpakalason kayo or what, but in case in your in the future, maka-encounter kayo ng ganito or maybe sa boards lumabas ang albuterol poisoning, you should always know that propranolol is one of the antidotes. Okay, so to consider, recommend to give selective beta blockers like for example metoprolol if albuterol is being administered or increase the dose of albuterol to reach maximum therapeutic dose. So dalawang ang i-recommend mo, either ibigay na lang yung metoprolol kasi nga ang metoprolol selective siya, beta-1 selective. Or either taasan na lang yung dose ng albuterol para para ma-cover up din yung effect ng propranolol kung kailangan mo talaga siyang i-gamutin yung asthma. Okay? Okay, next example. Pia was rushed in the emergency room complaining that her right upper quadrant starts to be tender, complains nausea, vomiting, and diaphoresis. Her mother told the attending physician that she took 2 bottles of paracetamol 500 milligrams because she broke up with her boyfriend. Oh, Pia. Pia's physician ordered N-acetylcysteine or Flumoxyl to be administered orally. Okay, ano nangyari sa case na to? Paracetamol plus N-acetylcysteine is the drug that we are going to focus. Pero ano ba nangyari? Nagkaroon siya ng paracetamol poisoning. So paracetamol when taken in bulk, like ito nga yung example ng antagonism na sinasabi ko kanina. If taken in bulk like 10 grams ingested over 24 hours or 6 grams ingested over 48 hours period or greater than 100 milligrams per kilograms per day ingested over a 72-hour period, it will produce technically a toxic compound called NAPQI. N-A-P-Q-I, NAPQI. Hindi napkin, NAPQI. Okay, so now acetylcysteine is given as an antidote since it donates thiol group to increase the glutathione in the liver to further metabolize and act on the toxic compound that the paracetamol produce as an antioxidant and facilitates conjugation. Di ba ang metabolism ng glutathione, kung na-discuss ko sa organic medicinals ninyo, ang glutathione metabolism is conjugation reaction. I believe that's phase 2 na to, phase 2 reactions to. Phase 2 reactions of metabolism. So, ang ginagawa natin dito is i-reduce natin ang toxic levels ng NAPQI. So, kapag merong kang na-encounter in the future, like for example, a patient was admitted to the hospital with paracetamol poisoning, ang unang-unang papasok dapat sa utak mo ay N-acetylcysteine or Flumoxyl. Kahit na pang-ubo to, well, Flumoxyl talaga ang antidote. Or pag lumabas to sa boards, sana matandaan nyo na ang antidote para sa paracetamol is N-acetylcysteine. So kanina, di ba, sabi ko, Ang glutathione sinasabay sa vitamin C intentionally. Ito yung isang example natin ng intentional drug interaction. Pero may mga iba din patients na sinasabay si glutathione kay fluoxetine or N-acetylcysteine. Bakit? Kasi in-increase niya yung synthesis ng glutathione. So, di ba, may mga interactions din naman na hindi naman sila harmful pero intentionally ginagawa natin sila kasi nga gusto natin na mas maging effective tayo gamot. Okay? So lastly, NSAIDs and thiazides. NSAIDs when taken too long will cause edema. Alam naman natin that edema causes retention of sodium and water. Remember, where sodium goes, water goes. So if our fluids are not excreted normally, meaning other cations will also remain in the system which may cause hyperkalemia. Eh, hindi nga lumabas yung sodium mo, eh, ba't lalabas yung isa, di ba? On the other hand, sabi ko nga kanina, si thiazide nag-act sa kidney para hindi ma-reabsorb si sodium. So meaning, magkakaroon ka naman ng hypokalemia kapag taken in a long time. So kapag inom ka ng thiazide, sige, dahil maintenance mo to, you have to consider also na magkakaroon ka ng hypokalemia if taken too long. Okay? So, if you would analyze, NSAID and thiazides has an opposing effect in terms of potassium levels. But on the other hand, NSAIDs with less than 2 grams per day, even if it's less than 2 grams a day, hyperuricemia may occur in the long run. Tapos, thiazides, it also causes hyperuricemia in the long run. It may cause additive effect even if the dose of NSAID is low. Severity will depend on its dose. So, ang severity ng hyperuricemia ay magdedepende sa dose ng NSAIDs. Pero kasi, even if it's less than 2 grams per day, hyperuricemia will occur. So, meaning, hindi lang sila ang NSAIDs and thiazides, they do not just only have their antagonism effect, but they also have an additive or potentiation or any pharmacodynamic effect in terms of hyperuricemia. Okay? So, these are some of the examples of our drug interactions, and we will tackle more in the next videos. And this is the last part of the introduction in drug interaction. So, mas intense discussion natin in the next videos. And so, I hope to hear from you in the next videos. And thank you for your attention. Goodbye. Thank you for listening.